we are. We're back with another episode of MedChat Monday, Healthcare Specialty Series, where we dive into the different healthcare specialties that exist out there to give you a better idea of what potential specialty you want to pursue if you go into medicine. So today we're going to focus on ENT, ears, nose, and throat. And to discuss this, we have Dr. Block, who is an ENT specialist, to give us some insight into his journey about becoming an ENT. So Dr. Block, welcome to the show.
Dr. Ross, thanks a lot for having me. Great to be here.
So we want to get an idea about what it takes to become an ENT and what your journey is about and how you got where you are today. But let's start with a very simple question. Why did you decide to become a doctor?
I don't know how simple that really is. I think it ends up being a pretty complicated decision. I wasn't one of those people that felt like there was a calling. You know, I wasn't born with some innate desire to be a healer. And I would argue that for those who did feel that way, maybe allowing your 8-year-old self to make career decisions for you isn't the best thing to do. So I think a lot of reflection along the way to make sure that that's what you want to do is really important. Yeah, no, I didn't make the decision to go into medicine until I was towards the end of college. I was a science major, I was a bio major, so I had all the prereqs done. But it wasn't until really I studied abroad in Jerusalem, and so that is a very incredible city, right? Very meaningful, very deep history, and to go to a place like that really allows you to reflect on important decisions in your life. And also just getting away from your college experience helps you reflect on what's important in life, what's important to you. So I decided to do something that I thought was important with the skills that I had, right? Science and math, physics, chemistry were my strong points. So, if you want to do something meaningful, you can either do research. I didn't see myself pipetting. So medicine was the choice.
Okay, so fast forward, you start your first 2 years of medical school. Did you have an idea that you were going to focus on ENT?
I had no idea. I was one of the people that started out, you go to your interviews, you have to tell them you have some idea. But, I think a lot of that is just, you're being forced to say something rather than saying, listen, guys, I know you accepted me, or you're thinking about accepting me into medical school, and I have no idea what I want to do. Not a clue. I'm not sure how well that goes over in an interview. So I'm sure I had something to say. But as I went through medical school, I really liked the physiology of cardiac pathology, specifically pediatric cardiac pathology, and just understanding the fluid dynamics behind the different pathologies I thought was really interesting. So I thought I was going to be a pediatrician and then go on to be a pediatric cardiologist. And during my pediatric cardiology rotation, I realized that a lot of what they do is benign murmurs. So what do? You're a pediatrician, here's a murmur, they send you in, you get an echo, echo's normal, you're fine. So it's just a lot of these effectively you're giving people good news, which is great. But at least where I went to med school at that time, there wasn't a whole lot of intervention going on, right?
So your intent in the beginning was potentially to go into cardiology, pediatric cardiology. You never thought you were going to venture into ENT.
No, and in fact, because I thought I was going to be a pediatrician, during my electives, my first choice was ophthalmology. Why was it ophthalmology? Because eyeballs grossed me out. So I wanted, as a pediatrician, to get used to eyeballs so that when a kid came in with an eye injury, it didn't gross me out. But I got my second choice, which was ENT. So that was my elective. And then I saw what the ENTs did, and, they did some incredible stuff. It was actually a pediatric ENT rotation. So I got to be able to see, to see kids all the time, yet be in a surgical specialty where you're doing a lot of intervention. Now, fast forward, I'm not a pediatric ENT. I'm a generalist, but about a third of my practice is pediatrics, tubes, tonsils, adenoids, branchial cleft cysts, thyroglosal duct cysts. So I see a good number of kids, and it's mixed in with plenty of adults as well. So,
but I think this is a great example to show people that you start medical school, you might not know exactly what specialty you're going to end up pursuing, until you get exposed to, or by chance get exposed to, a certain type of specialty.
Well, and the reality of the situation is you have no idea what you're getting yourself into, even after you pick a specialty, right? Your 1 week rotation, your 1 month rotation, your 2 month rotation happens to be in 1 or 2 different institutions. And those institutions tend to be very specific. They're what the program director is like, what the chairman is like, the type of pathologies that they happen to see while you're there are going to be limited. So my life as a private practice otolaryngologist is very different from being a resident. The pathology that I saw as a resident in a tertiary care hospital is very different from the pathology that I see as a private practice attending. My life now, I had no idea what it was going to be like even after finishing 5 years of ENT residency. My life now is very different than what it was. And it's not just because the hours are different or because I make my own schedule. It's just the pathology that I see and the rate at which I see them, very, very different in private practice.
So how would you define ENT to someone who doesn't know what an ENT is?
Well, one, I want to make the distinction between an ear, nose, and throat doctor and an emergency medical technician, because that's common confusion, an EMT versus an ENT. But yeah, we do all pathologies of the ear, nose, and throat. And there's certainly overlap with us and other specialties, right? Like ophthalmology has oculoplastics, right? We have facial plastics. So there's overlap in those fields. There's overlap with what an oral surgeon might see and what an ear, nose, and throat doctor might see. But the things that are just us are the paranasal sinuses. So someone comes in with sinus pathology, someone comes in with throat pathology. That's above the level of the esophagus. So now we're not overlapping with thoracic surgery or GI. Voice complaints, that's all us. And then ear problems. There's nobody else that's going to do an ear problem unless it's like a auricular problem, right? If there's a deformity of the auricle, that might be plastics, that might be us. But when you get into the internal external canal, the drum, the cochlea, that's all us. So any ear, sinus, or throat pathology, you're going to see an ear, nose, and throat doctor.
So what was it about that pediatric ENT elective that you took that said, you know what, maybe I'm going to be inspired to become an ENT?
So the penultimate case was a kid with huge adenoids. So for those who don't know what the adenoids are, Waldeyer's ring is 3. This is going to be on your exam, so make sure you take
attention,
notes.
Everyone.
Yes. Is the tonsils, which are the palatine tonsils, that's what everyone thinks of as the tonsils. They're the adenoids, which are the way back of the nose. If you run your tongue along the roof of your mouth all the way to the back, your tongue is now pointing at where the adenoids sit. And then the lingual tonsils, which are on the back of your tongue, like the way, way back of your tongue. So the adenoids sit in the back of the nose, and they're effectively the back door to the nose. And if they get big enough, then you can't breathe out of your nose. And if you've ever tried eating while you're holding your nose, it's really tough. So if you're 2, and every time your mouth is full, you have to, or every time you take a bite of something, you have to hold your breath to chew and swallow because you can't breathe through your nose. You're not eating that much. So in its more severe form, big adenoids can cause a failure to thrive. So these kids aren't gaining weight. Now you take them to the operating room, you take out their adenoids. It's a very straightforward procedure. There's minimal risk involved.
But a very super interesting case, though.
Yeah. And it's, I mean, on the other hand, it can be mundane, right? My colleagues that do head and neck cancer surgery, where they're doing these large resections and repairing them with free flaps, they're going to think that an adenoidectomy is boring. But to me, I still enjoy them after, I'm 8 years out of residency. So I've been doing them now for 13 years. And I don't know, it's probably numbers in the thousands how many I've done. And I still enjoy it. I still enjoy it because I see them before and I see them afterwards. And you do something that's relatively low risk, and they do almost universally do incredibly well.
But it also makes a huge impact on their lifestyle and their ability to eat and to thrive in terms of their growth.
Yeah, now they're back on the growth curve. Okay,
so it was that particular case that was one of the inspirational cases that made you say, you know what, ENT is the field that I'm going to potentially pursue.
Exactly. There's a lot of minimally invasive procedures that we do either in the office or in the operating room that end up causing a large change to the quality of life of the patient.
Now, after that rotation, did you pursue other electives in ENT?
So I did an away rotation at Georgetown, which is where I ended up doing residency. My program at the time I went to med school at SUNY Buffalo, which didn't have an ENT program, which can put you at a distinct disadvantage. So I did an away rotation at Georgetown, and that's ultimately where I ended up getting accepted into residency. So I did a home rotation. I did a 1-week rotation as a third year, and then a home rotation as a fourth year, and then another rotation as an away.
How important are these rotations, these elective rotations?
So you'll have to ask someone who's a program director, because they're the one who are ultimately making the decisions. Although, as you know, the residents are certainly involved in, at least some programs are certainly involved in decision making. So I think the away rotations can be helpful as long as you make a good impression. I think the impression that I made, I think I did a reasonable job during my rotation, but we gave a grand rounds at the end. And I think what ultimately got me into the program was I just killed it at the grand rounds.
But it certainly sounds that it seems at least that by going to Georgetown, doing the elective rotation, that gave you a little more recognition, maybe from the directors or even from the residents, that this particular medical student could thrive in this environment.
Oh yeah, absolutely, absolutely. I mean, you run the risk of making a bad impression, but I think in general, especially for small programs, right? We were a 3-person we still are a 3-person program. You want to make sure that you're going to be able to get along with the person. So someone that you meet during an interview, you're not going to be able to get as good an impression as someone that you worked with. So if you worked with someone and you know that you like them, the devil you know is better than the devil you don't.
How important is it to do research for getting into an ENT residency program?
ENT is one of the more competitive specialties, so I would say it's important.
It's definitely up there. We know it's top 3.
Yeah. Oh, I don't know if it's top 3. It might be top 3 now, but research is important because you have to play the game, and part of the game is telling them when you interview that you don't want to go into private practice, you want to be an academic, and you want to do lots of research, and you want to that's what they want to hear, right? They want to be training the next program director. They want to be training the next department chairman. And you don't get there by not doing research. You get there by doing research. So you have to do, it would be very challenging to get into a residency that's competitive without doing some research in the field.
What type of research in ENT do you think is important?
Oh, I mean, it varies so widely. I mean, I did a chart review. I mean, I did a retrospective study of charts in the pediatric ENT practice that I was working with. My mentor was unfortunately she passed away, but she was a pediatric ENT. So she took me under her wing and really helped me do the research. And mentorship is really hugely important. So it's important to find someone in your department that you can do the research with. Then they'll be able to write you a recommendation. Then they'll be able to speak for you. They have friends in other departments. They'll be able to call them on your behalf, right? This is a game, and you have to know the rules of the game, and you have to be willing to play the game. So that's important. And also, you and I, we're standing on the shoulders of giants. We're standing on the shoulders of the people that did that research. So I'm not saying that research isn't important. I'm just saying if you don't like it, I'm sorry. You gotta find a way to do it anyway, because that's how you become a competitive candidate. But I can't say what type of research, because there's so much out there. I mean, you could do surgical simulators, you could do a retrospective study, you could do biochemical research. When I was a resident, I did a whole lot of pipetting on MUC5B, a mucin producing enzyme in the middle ear of a mouse middle ear epithelium. So, it really runs the gamut. And my field has such a huge variety of what we see, right? You can see dizziness and vocal cord problems and swallowing difficulties and ear infections and head and neck infections, head and neck cancer, sinus cancer. So
there's a lot of variety in the field of ENT. So
yes.
You hinted at the importance of networking. Does that mean as a medical student you would advise attending ENT conferences?
Well, you should at some point present your research, right? You should have a poster presentation. You should have an oral presentation. You should have a venue for presenting your research because your competitors will. So you need to go to a conference if for the only reason to present your research. But if you present your research and a program director sees it and they remember it, again, keep in mind, I'm in private practice. I'm not a program director, and I'm 8 years out from having interviewing medical student candidates. But, if you just think about it, this all makes sense. If you see someone present a fantastic bit of research that you remember, and then you invite them for an interview, right? What are the odds that you're going to take that person over someone who has got a sharp looking suit, but you have no idea who they are?
Totally makes sense. So let's fast forward to your years as a resident. How many years is an ENT residency? And can you take us through what those days look like as, what's a typical day in the life of an ENT as a resident?
So it's evolved a bit. So when I was there, initially it was 2 years of general surgery. Then it was 1 year of general surgery. So I was there when it was 1 year of general surgery. But now you're more owned by the ENT program than you are by the general surgeons. Like I did a month of transplant and a month of urology. I'm not sure what that gets me in terms of ENT education. It would have made more sense to do maybe some different rotations. But now you're owned by the ENT, so they get to decide what rotations you do. So the first year is different now. I can't really speak to what your rotations tend to be, but you're not an ENT per se. You might spend a couple of months on ENT, but you're rotating through other fields, and rightly so, because you should be learning about plastic surgery and oral surgery and anesthesia and emergency and intensive care. These are all important to being a well-rounded otolaryngologist. Second year is really the most grueling year of residency because that's your first year as an ENT. You're taking the most call. It's the biggest learning curve. And you're rotating through different services. So ENT, you're going to be in different hospitals. You might be covering different attendings. There's a lot of pediatrics during your first year. So that's when you're doing tubes, tonsils, and adenoids, kind of the bread and butter stuff that I'm doing now. You might be doing some beginning sinus work and nasal work. And it really it depends on the program. At least in mine, that's where you started to do ear surgery in your third year. Your second year also doing head and neck cancer surgeries, but you're generally assisting the attending and the chief. So you're just getting your feet wet in terms of the bigger surgeries.
I'm assuming you're doing a lot of didactics as well in between the surgeries and seeing patients.
Yeah, I think we had 2 half days of didactics, right? One morning of grand rounds and lectures and tumor board, and then another that was protected time where the residents did. I'm not sure if it's still around, but it became a national phenomenon, and it was started by I think she's now the program director of Georgetown, Sonia Maluxadeh, something called Cochlea, but misspelled. So Coclia. Cochlea is spelled Cochlea, but Cochlea is an acronym for something about teaching and learning. And so it's I think most programs do it, and it's just it's the didactic learning curriculum.
How many years are you in a residency program for? Is it 6 years?
It's 5. ENT is 5 years. So first is the general year, and then 4 years of ENT, and about half of us go on to fellowship. And half of us don't.
So what are the options for fellowships?
So interesting. I'm going to just drop my podcast. I'm going to a little ad for my podcast here.
Please do.
I have a podcast called The Physician's Guide to Doctoring, which is just for the motto is everything that you should have been learning while you were memorizing Krebs cycle. So we run the gamut from everything you need to know about advocacy as a physician, common misconception about the Affordable Care Act, how to have effective conversations about weight loss with patients, how to develop good habits. So I interview people who are experts in that field to learn all the things that would benefit us as physicians to know. And then different specialists, right? And so I had an ophthalmologist on, and the title of the episode was What Weighs an Ounce and Has 7 Fellowships. So apparently you guys in ophthalmology have more fellowships than us, even though we're ear, nose, and throat, and you are just the eyeball. But our fellowships are otology, and they're either 1 or 2 years. So that's you're covering ear pathology, mastoidectomies, cochlear implants, acoustic neuromas, working with neurosurgeons a lot, and dizziness problems, hearing loss. There's also laryngology, where you're doing voice and swallowing problems, rhinology, where you're doing, it's not really rhinoplasty, it's more sinus. So you're doing complex sinus disease and sinus cancers, also approaches to the skull base or CSF leaks. There's facial plastics. Sometimes it's cosmetic, sometimes it's cosmetic and microvascular reconstruction, where you're fixing the complex wounds left by head and neck cancer. So head and neck cancer is another one. I think I covered. And peds.
Obviously peds. So let me ask you a question. I'm assuming research is important to get into these fellowships, right? So you start research in medical school to get into an ENT residency. I'm assuming you should continue as a resident if you can to contribute to papers.
Yeah, if you are expecting to get into a fellowship program, you should have research. I don't know if you necessarily need to have research in their niche field. Like if you do facial plastics research and you apply to rhinology, because it turns out you are more interested in rhinology towards the end of your residency. I don't know how important it is. I don't want to say it's not. Again, not a fellowship director. I'm not sure what they're looking for. But
well, you have insight. You went through the process.
Yeah, actually, I did. I applied for a rhinology fellowship and I was not accepted. One of the reasons I'm a general ENT. I didn't do much research, and during my interviews, I was open about going into private practice. So I think they're looking to train the next generation of academic rhinologists. They're not looking to train someone who's going to open up a private practice next door to them and be their competition. So this is again where the game comes in. I had like one fairly weak poster presentation in rhinology, and really no connections in the fellowship directors. So that made it more competitive for me. Not to say that if you were from my program had gone into,
I know you're happy where you are now. I could see that, but I'm curious if you were to go back and you wanted that particular fellowship. I'm assuming you would have spent a little more time maybe doing research in that particular area.
Oh yeah, I wouldn't have spent my third year research rotation doing, mucin secretion in the mouse middle ear model. I would have done something much more rhinology specific, right? Because then I'd be able to again meet people at conferences. Then they'd know who I am. It would have made me a stronger candidate in that field.
So about 50% of the ENTs after their residency, I'm assuming they go into general practice. The other 50% go into their fellowship. Could you take us through your fellowship years?
Oh, no, I didn't do a fellowship.
Oh, you didn't do a fellowship. Okay.
I didn't do a fellowship.
So when you finish your training, whether you finish as a fellow or you finish as a general ENT, what are the options? Can you go into private practice? Is it still possible to go into private practice? Or do you have to join a larger group? Do you work for the hospital? What are the options for someone who goes through an ENT intensive training? What are those career options post training?
So I think hanging up a shingle and being your own boss and not being part of a group, I think those days are over. There are very few fields that can do that. I think there are psychiatrists that do that. There are dermatologists that do that. And if you do cosmetics, you can do that because then you don't have you're not taking insurance. Right? You don't have all the infrastructure required to actually get paid. It's not like you submit the bill to the insurance company, they just pay you. No, you need a group with 10 people that are calling them and hounding them and making sure that you actually get your bills paid. Otherwise, you're not keeping the lights on. So in order to have that type of infrastructure, you need to be part of a group. The size of the groups vary. You can still go into private practice, but I wouldn't, unless you're doing facial plastics, I wouldn't. I don't foresee people actually being able to go into practice by themselves.
And how about the option of working for the hospital?
So yeah, you can work. Clearly, you can work in academics. You can work for hospitals that don't have residency programs. You can work for hospitals that have residents that aren't in otolaryngology. There are plenty out there. ENT, we only graduate 250 people a year. So there aren't that many hospitals that have ENT residents in them. There are plenty of hospitals that don't. So you can work for those hospitals. You can work for a multi-specialty practice, Or you can work for my practice and you're familiar with them because we're big. We're the biggest ENT and Allergy Associates. We're the biggest ENT practice in the country, hands down. I think we're probably 3 times bigger, and we're physician owned and physician run. So we have a C-suite, right? We have a CEO, CFO, COO who are non-physicians, but the board and the president who ultimately run the practice, they don't run the nuts and bolts in practice. These guys all have full-time practices, but they oversee the running of the practice. These are all physicians.
And you still feel like you have autonomy in terms of running your own shop.
Yeah, I mean, listen, when you're part of a 200-person plus practice, you don't have that much autonomy because the decisions are made by the board and the board is elected. So what I have to say is 1 out of 200, although 150 because we're about 150 partners and 50 associates. I don't have that much say, but the way our structure works is there are committees for everything. So I have 2 responsibilities with my group. I'm chair of the audiology committee. So we have the largest audiology practice outside of the VA system. We employ more audiologists than anyone except for the VA. So I oversee the operations. So if our director of audiology ever has a question, he asks me. If I need to, I'll forward it to our committee, and then we'll make a decision that sometimes gets forwarded to the board. So if you're interested in like electronic medical record or our website or marketing, if you think we don't do that well, get involved in the committee.
And again, that's the reason why if you join a group, you're going to have the option of not only taking care of patients, but you're going to be able to learn maybe some of the marketing side or the management side of being part of a larger practice.
Yeah, and also that's one of the reasons I started my podcast, is it's a physician-facing podcast for all the things that we should have been learning that didn't. I haven't had an episode yet, but I will be soon on marketing and management, and I just did an episode on coding. And so all the stuff that we probably not learning that much in medical school and residency, certainly not enough.
Well, we didn't have time.
Yeah, you're too busy learning all the didactic stuff and becoming a good doctor. But yeah, my practice is kind of, I don't know if it's unique, but that's the thing that really makes us special and stand out and appealing for people to join.
Dr. Block, I have a question. Do you see an equal amount of men and women in the field of ENT? No, and that's rapidly changing. Okay, so there are more women entering the field of ENT.
I'm not privy to those statistics, so I don't know. But from just anecdotally, our practice is predominantly men because 30 years ago, that's who we were training, predominantly men. But who are we hiring? I don't know if it's equal, but it certainly might even be more women than men. In my residency program, I was 1 man and there were 2 women. And then in the years after me, it was more often female than male. So otolaryngology is certainly shifting rapidly in terms of the gender split, to the point where, there might be more female residents and new attendings than there are men.
What do you love about ENT?
The variety. Because I could be spending one day resecting a neck mass, and the next, in the morning, and then the afternoon I'm cleaning out earwax. And the neck mass might have been in a 70-year-old, and the earwax might be in a 2-year-old. Or I'm working up dizziness, or I'm doing an office biopsy, or I'm doing an office sinus procedure, or I'm doing an operating room sinus procedure. Like the variety of what we see and what we treat varies so widely. There are a lot of the family medicine specialists or generalists, I guess, are fond of saying that they take care of everyone from birth to death. And in ENT, we get to do the same. Really, I take care of patients I take care of 3 generations of a family, sometimes 4 generations of the same family, right? I'll see a newborn for a tongue tie at 4 days old for laryngomalacia, and then I'll see, an 80-year-old with swallowing difficulties or dizziness as the next patient, and maybe even the same family. So, one of the great things about my specialty is the variety of things that we treat, but also we get to see patients of all ages. So I get to have that pediatric practice, but I'm not just seeing kids, tubes, tonsils, and adenoids all day long. right? There's more variety with the adults.
What would you say to a first-year medical student who was considering going into the field of ENT? What would you do to inspire them to venture into ENT?
Well, start doing research now. I think that speaks to what you were saying earlier, just the importance of it, but also that'll give you more exposure to it, right? Typically, we don't get exposure to different specialties until we're third years, and that's a lot of times when your opportunity to do research has already passed. So try to get some exposure, and also the variety is also one of the great things about it in terms of the types of practice you can have, right? Like, an academic otologist is only seeing dizziness and ear infections and ear drainage and cholesteatomas, and which is his partner next door is seeing just head and neck cancer. And their 2 days are very different. So even if you go into ENT, there's so much variety, academic versus private practice, to what your life will look like. That even, you might find out, this isn't the specialty for me. Well, that's unlikely, because there's
a variety of things that you can do in ENT. So don't get turned off if you have an elective rotation in ENT, because that is not representative of the entire field.
Yeah. And I think it's important to figure out what you don't like more than what you like, because I probably would have been happy doing ophthalmology or urology or anesthesiology, right? There's so many different things that I probably would have been, if I never did an ENT rotation, that I would have been perfectly happy doing. And I think my advice for a first-year medical student would be try to get exposure to as much as possible, but don't stress yourself out that there's one right specialty out there, right? There's not. There's a range of things that you're going to like more and things you're going to like less. But there's not like this aha moment where you're like, oh, this is the thing for me and nothing else is for me, right? That just, if you think about it, it doesn't make any sense. So don't put so much pressure on yourself and try to get exposed. The other thing is don't make your decision based on the people you rotate with, because you might rotate with a resident who's a jerk and then you hate it. And then you're not going to want to go to that field. Why? Because that person, that resident just his girlfriend just broke up with him. So he's in a crappy mood. He's going to not be so happy, and you're not going to have so much fun. You're not going to learn anything. And then you're like, this field isn't for me. No, it's hard to make that decision based on that type of experience, but you have to recognize that the individuals that are in that particular program, or whoever you spend the most time with, is not representative of the entire field.
Okay, well, Dr. Block, I want to thank you so much for the time that you took out of your busy schedule. You have certainly inspired future ENTs, and this interview was very inspirational and insightful about the ups and downs and what to do and what not to do if you really strongly are considering pursuing ENT. So thank you so much for your time and patience.
My pleasure. My pleasure. I just want to give one more plug to my podcast.
Please.
For all those med students out there, because one of the things that we also cover on the podcast is what every doctor should know about X field. So I get different specialists on, like an ophthalmologist or a spine surgeon. What should every doctor know about the spine and spine care and spine pain, or ophthalmology or ENT? I'm going to be having a laryngologist on soon, so voice problems and throat clearing, post-nasal drip we talk about. So if you're interested in learning more about other specialties, that's a great way, because I have different specialists just talking about their field in general and what non-orthopedic surgeons need to know about hip injuries and shoulder injuries, as well as all the stuff that you should know. So that's the Physician's Guide to Doctoring. So if you go to physiciansguidetodoctoring.com.
We're going to share the link below on YouTube and Facebook, so make sure to check it out.
Wonderful.
Dr. Block's podcast.
And then my Twitter handle is @PhysiciansGuide. If you want to know my opinion about, anything, because it's Twitter, so you just throw random stuff out there, but I try to keep it mostly medically focused. So check out the website. It's available on wherever your favorite podcasts are found, like Dr. Ross's podcast. I'm sure I'm on the same platforms as well, iTunes and Stitcher and the rest of them. So check it out.
Okay. Thank you so much, Dr. Block.
Thank you for having me.